Change podcast, where we highlight, celebrate, and extol others doing amazing things in healthcare and beyond. I'm Dr. Otten, your host, and today's topic is Emerg simulation. And I tried to do like a French accent, but I probably just totally blew that. Anyways, I've got two incredible ER physicians with me today. I'm going to start with Shawn. Shawn is an emergency medicine physician who actually is in Ontario, Canada. And he's also the founder and director of Dynamic Simulation, a mobile clinical resuscitation simulation program that travels to community hospitals across Ontario to provide simulation sessions to emergency and intensive care departments. Incredible work. And my guest co-host, is actually a longtime friend and colleague, Chris Port. He and I went to medical school together, and we both disagree on who introduced whom to one another the first day of school, but have been very good friends ever since. He currently serves as the Chief Medical Officer for Emergency Care Specialists in Western Michigan, and their work is incredible. I actually write about ECS in Ripple of Change not once, but twice, just because I think they're forward-thinking, they think outside of the box, and they're really trying to do positive and innovative things to make healthcare delivery in Western Michigan better. And I applaud their group for that work. Clearly that focuses on quality, value-based reimbursement, education, but also that wellness piece, which is so important. So I'm thrilled to have the two of you here today. I probably already talked too much and I only screwed up one name, so that's kind of par for the course. Chris, why don't we go to you for the first question?
Yeah. So thanks, and Shawn, thanks for being here. Looking through your website, Todd kind of gave me a little insight into what you're doing, but I'm really just interested in how you got this whole thing up and started, because we do a little bit with simulation here at ECS, and seems like quite a lift to build a mobile unit and be able to go out and go around. So.
Absolutely.
Just want to kind of know the origin of how you got going with this.
Absolutely. No. Well, firstly, thanks for having me, Todd. I know the work that you're doing is amazing, and I'm very excited to be here. So, Chris, thanks for the question. So dynamic simulation, I started this around the time of COVID. So I work in a community hospital, as Todd mentioned, and community hospitals don't really have a lot of good access to simulation or skills sessions, anything hands-on. You got to travel to different communities, like largely bigger centers, like tertiary care centers, to get anything similar. So during COVID, of course, everybody was questioning, how do we take care of patients that are critically ill with COVID? How do we safely intubate them? Can we put them on BiPAP? Questions like that. And so having just actually graduated from the emergency medicine residency program at Western, what I did a lot of simulation there. And I thought, I really like simulation. Why not give it a shot and see if I can integrate that into the emergency department at the community hospital I work at. So I ran a couple of days of sessions for the emergency physicians, and it went very, very well, to the point where a lot of my colleagues were asking if they could do more. And fast forward a year later, and dynamic simulation was created. And so since that time, it's been a lot of building the cases, building the program. So a lot of the work goes into actually writing good, well-constructed, peer-reviewed cases. So every month, I think starting in April 2020 or so, I wrote a case and had somebody peer review it, one or two people typically, and then ran it in Chatham and got some buy-in from nursing staff, from respiratory therapy staff, and Chatham is a community hospital that I work at. And so ended up taking off from there. And got a lot of interest in terms of buy-in from staff and how well it was received, but also from the financial aspect of things. The foundation at my community hospital got a hold of it and got an ear of it, and between the two of us, we decided to try to go out and try to get some funding for it, and we're able to do that. And now it's basically just been trying to integrate the program into as many hospitals as possible across the province.
This is amazing stuff. I love the outside of the box thinking, and the fact that you were able to, as a solo entrepreneur, if you will, facilitate this and really build it, and now looking to scale it. And I think the interesting part for me is, having been in the healthcare space, I can just hear like C-suiters go, well, what's the ROI on this, right? Like, what's the ROI on doing simulation? And I would actually be curious probably to hear from both of you on this, because I can see, the ROI in terms of quality care, avoiding problems, less lawsuits, better care, all these things, and so you might not have an exact number that you can quote, but you've got like probably 1,000 things that will be better as a result of it, which will, create lower costs. I'd love for you to maybe dive into that a little bit, Shawn, if you would.
Absolutely. So, of course, in addition to the education aspect that you get out of these simulation sessions, and again, all of these sessions, we try to make them interprofessional. So we have, RT, nursing staff, nurse practitioners, physicians, residents. And so, you're going to get a lot of education from it, but from the return of investment piece, we've made a lot of improvements in different departments. They're not necessarily measured, but many examples come to mind. Like, I think a very very common one is the use of cricothyrotomy kits in a surgical, airway need, like an emergency. And so a lot of hospitals, I find, grab like something called a Melker kit, which is great. And there's no, I'm not bashing Melker kits, but I think if you don't do cricothyrotomies often, which I don't think many emergency doctors are, it's a bit of a complicated thing to use. So, what we do in Chatham, and what a lot of other hospitals are doing, is just putting a scalpel, a bougie, a 10cc syringe, and a 6-0 endotracheal tube in a bag, and just do the scalpel finger bougie technique. And so we've made a lot of changes to a lot of departments, and integrating that into their difficult airway carts, for example. Many things come to mind, many things. Going through protocols, when a hospital is wanting to integrate a massive transfusion protocol, or code stroke protocol, we've been helpful in coming down and doing a simulation for them based on that, and help integrate that more seamlessly and more safely into their emergency departments as well. So.
And Chris, I'd like to hear from you maybe a little bit along these lines too, in terms of the return on what should be kind of a no-brainer from an education perspective. And I believe ECS, correct me if I'm wrong, there's a component of CME related to the skills lab, right, or symposium. Is that true?
There can be. We started doing some simulation for our shareholder partners. I was trying to think back. It's either 2018 or 2019, and then we're now up where we do at least 4 different sim labs each year. We try and rotate around because we're in 14 different hospitals in Western Michigan, so we go out to sites and then have a big sim lab day that we call our Symposium. That's going to be in the fall, and with that we do connect it with continuing medical education credits for those that attend. But I mean, truthfully, we started it kind of to your point, Todd, as a provider wellness. There's like a cricothyrotomy. There's multiple procedures that are rare but life saving, and we didn't want the first time you're seeing the new pacer kit to be when you need to be floating it, right? So we wanted to have the opportunity for the providers to get comfortable with all this equipment, to practice these rarely done procedures, just so you're ready in the moment. And we don't get funding for it, but we think it's the right thing to do. So we carve out the time and try and make them fun and educational at the same time.
I just want to repeat what you just said. The right thing to do. I hope all the listeners picked up on that little nugget there. because that is a big part of the reason why I think ECS is phenomenal. I actually was blessed to attend the symposium last year, and I'm a family physician, so I'm not planning on doing. I think Chris got really excited about a lateral canthotomy, and I was like, "Oh, that seems cool." I'm not even sure I'm interested in watching necessarily, but he was very excited, so I was excited for him. And do you get that same kind of excitement from the people that you're taking this stuff to, Shawn? Do you get that same level of excitement and wellness and appreciation, et cetera?
Absolutely. I think, like as Chris said, I think there's a lot of anxiety in emergency medicine when you haven't done a procedure in a certain number of weeks, months, or years, and sometimes ever. And so when we come down, and part of what we offer is full day skills days. So we instead of just doing sim, we will do kind of a round robin kind of thing, around the table, and you can go in and we'll show you how to do certain procedures like awake intubation, Blakemore tube insertion, lateral canthotomy, as Chris said, and then some of the more common things like lumbar puncture, chest tube insertion, and the excitement level is just off the charts usually in the room, because and you can just kind of feel the anxiety that was there coming in just kind of go down, and it feels so good to be part of something like that, where especially when you get like a text or an email the next day, or even a week or month or a year later, that's like, I took this course and I haven't put in a chest tube in so long. And, 2 weeks later, I put in a chest tube and I felt so much more comfortable doing that. And I think like if that doesn't talk or speak to physician wellness, like improving from this, I don't know what does. So it's it's been very rewarding that way.
Yeah, you're mentioning all these different devices. You alluded to like foundation. I know we don't own any of the equipment we use. We have a couple of different sources, and some of these sims can cost tens of thousands of dollars for these simulators.
Yeah.
Where do you source your equipment from, or is it all grant funded, or how did you get all of it?
Yeah, so the equipment, as far as like actual like chest tubes and endotracheal tubes and things like that. So the hospital that I work at's been very kind, and anything that's expired, they know that I have this program, and it's generally going to be thrown out. So they know to just give it to me, and so that's been, I have to be I'm very thankful to them. As far as the actual like trainers, there's some really interesting websites that you can get good trainers from that are not absolutely incredibly expensive. If you kind of know where you're looking, I'm happy to share some of those websites and companies with you, though, like if that's okay, Todd, like if that's okay to share that information.
Oh yeah, of course. I mean,
Yeah.
a big reason why we do this, Shawn, is to help others out, around the country and try and make things better
Absolutely.
for everybody, particularly for patients. I mean, as a patient, I would love for whoever's putting in the chest tube to have some recent experience or practice
Absolutely.
putting in the chest tube, because that's not a fun one for sure as a patient.
Yeah, so there's a company called Your Design Medical. I think it's out of New York, and the founder and CEO of that company, is a small company, is an Emerg doc, and so he's made a lot of more cost effective models that are quite and I can say this with confidence because I've used the really expensive stuff and I used their stuff, is just as good, sometimes better, and gives you the exact same experience, and feedback from people. We've had, I think, like 400 people or something like that go through these courses. Nobody has complained about the fidelity of the models. So that's good. And then oftentimes what you can do is like find used mannequins online. And so, what I do, what dynamic simulation does is, we use an iPad for a vitals display. So we don't have like the really expensive setup and things, but the iPad's really good. And there's a good program you can get called True Monitor it's from Laerdal. It's just an iPad like subscription. It's a yearly yearly subscription cost. It's not astronomical. It's reasonable price. And then you can use your iPhone and pair it. And then all the vitals are dynamic. You can change it as the case goes on. So we use that, and then we will usually use a used mannequin, and it's usually just there as a passive mannequin. So, there's a lot of push, when you're kind of talking to some of these mannequin simulator companies. So, you want to get this really crazy wireless mannequin with all these things that it can do, but I think in reality, once you get to a certain level of fidelity, I think there's a plateau there in terms of what the learner is able to get out of it. At least that's what I found anecdotally. I don't know if there's actual evidence to back me up there or not. I'm sure there is. But what I mean by that is, being able to hear breath sounds or being able to, see drool coming out of the patient's mouth or something like that doesn't really add that much. It's more of especially when you're working in like an interprofessional team environment, we're really trying to push more of the, effective communication and then the specific goals of the case. So, it doesn't, most people are just looking at the monitor anyway, so it doesn't really add much. So, if you kind of get more of a passive mannequin, it does the job and they're a lot less expensive. Yeah. So it's just kind of finding ways to work around it and not always having to, spend that $10,000 or 20, 30. Sometimes these mannequins are like upwards to, $80,000 for a mannequin that, I can see its utility in like a big sim lab, but as a mobile, a mobile program that I literally put my stuff like in the back of my GMC Sierra and like take off down the road. Like it's, yeah. It doesn't really take that much.
This is fascinating. I've always got like a bazillion questions. One of the thoughts that came to my mind as we were talking, when I think about ROI and wellness and culture and all those kinds of things, now that I'm working for ECS and seeing the culture firsthand, a lot of what I was anticipating is just amazing to watch. And it's things like this that allow good organizations to not only retain their clinicians, but really attract good clinicians. And so when we're thinking about ROI, if something like a skills lab or a sim lab can help not only retain, but attract additional clinicians, you are saving a lot of money, not only from a recruiting perspective, but also a replacement perspective when we're talking about the cost of replacing a physician. That was a bit of a tangent, but I thought it was important, so I wanted to just say it, and there it is. This might be a good time to do a Ripple challenge question, and I really had a good one that came to my mind in the recent past. We might have to edit this out. We'll see how it goes. There's no rules to this. Answer it however you like. I think I'm going to start with Shawn here.
Sure.
And then we'll go to you, Chris, to see what you have to say. Shawn, have you ever sunk a boat?
No, I can't say that I have. I think, it depends on what your definition of a boat is. I've definitely, like my kid is 3 years old and he's got like toy boats and stuff like that. And I've like, intentionally sunk those boats, much to his amusement, but a real boat? No, never sunk a real boat.
And Chris, how about you? Have you ever sunk a boat?
Yeah, interesting question. I recently sunk Todd's boat.
That was a bit of a loaded question. If you want to give any more detail, feel free. But
I will say, yeah, it was at Todd's cottage a couple of weeks ago, which he has gracefully let us rent from him for the past several years, and this year we got to use the boat, and I have some pictures and even video that people took as we were going down right next to the dock. I will say we were able to salvage, bail out, and the boat is happily in full working order. But yeah, we had it underwater a couple weeks ago.
And I can attest to that. And I was expecting to see one level of sinking, if you will, when I was, watching the video. It exceeded those expectations. Very impressed. But it's an older boat, so I could see how all these Swiss cheese holes would line up, right? Anyways, but I'm trying to think if I've probably more of a never sunk an actual boat, but in terms of possibly puncturing holes in other people's boats with standing up for my colleagues and stuff. That's possibly occurred. I digress. Chris, I'd like to hear a little bit more about sort of the timeline for the symposium from ECS, and maybe how people can learn about that, and maybe we'll swing back to you then, Shawn, too, about how people can find out more about your work, et cetera, online, so on and so forth.
Yeah. So our symposium's in October, and we've toyed with the idea of starting to open this up to see if others are interested in going. So we think it's a good learning experience. I just asked our team. I think we had our group's large, so we had 120 docs and APPs at the last symposium. We house it at one of the local colleges, has a simulator that area that they let us use. It's actually a whole building, multiple floors, and so we get access to a lot of really high fidelity simulations, some really interesting stuff. Going back to when we started this, I was telling Shawn right before we started recording, our first one of these, we held one of our partners' bars. It was closed on a Monday. We set simulators up and had everybody in and did the education portion, but to the wellness piece, it then turned into a social hour afterwards, which is great because often you don't see your partners that often in a social setting. It's always when you're working. So we've tried to keep that piece in mind and try and always hook a social component to our education, and it draws people in, and it's good for learning, but also getting some time to hang out with your colleagues.
Beautiful. Shawn, tell us more about how individuals can find you, and maybe where you're going next, and you're going to be doing this full time, one simulation per day is what I'm understanding. I'm just kidding. I'm kidding.
No, of course. No, thanks. So yeah, I mean, you can find more about our program, Dynamic Simulation, at www.dynamicsimulation.ca. And there you can see, the upcoming simulation sessions that we have. So, since about 2 years ago, we've been to just over 20 hospitals across Ontario. We're, the ultimate goal is to continue to expand and to continue to provide the service to as many places as possible. Our team is growing. We have 3 additional people now on the team, including 2 nurses and another physician. And so, we want to be busy. Right now, half of my time is clinical medicine in the Emerg, and the other half is doing this. And I'm very happy with things that way for now. We haven't done anything in the States before, but if there are people that, feel that their hospital or group might benefit from our services, we are also happy to, make arrangements to come out to wherever you need us. So we'll just sort out the details later. But if you contact us at our website, I'm happy to get in touch with anyone.
Absolutely. Chris, it looked like you were going to chime in there. Sorry.
No, I think it's great. Again, we've done all of our simulation and procedural stuff internally. I love the idea of going out and some outreach and being able to reach other communities. So,
absolutely,
if you're coming to the States, great. But I'd also kind of be interested in maybe there's a way that we could do that for other groups that aren't inside of ECS and kind of share the knowledge that way.
Absolutely. Yeah, we should definitely chat. Yeah, absolutely.
Oh, sorry, Shawn.
Yeah, we should. I was just saying we should just definitely chat, Chris, about that. I think there's so much opportunity, and things can be, like I said, like I'm not, I don't think I'm a genius. I don't think I figured out some kind of way to, figure out the system on how to deliver these simulations to different groups. I just think you just have to have the passion, the drive to do it. I love teaching. I love simulation, and I don't mind, traveling. So that's really all you need, to be quite honest. And you got to like sitting there and writing the cases and coming up with things, but that's fun. You're kind of like playing God a little bit, especially when you're in the background and you're, what's next in the case, and they don't. So it's always fun to see what's going to happen next.
I'm curious on generating the cases. Have you started to use like generative AI in case development at all?
So that's a great question. I kind of played around with like GPT-4o, and I'm all about, AI, I love it, but they're not. It's not quite there. Not quite
Yeah.
there. It's helpful in terms of some ideas, but to use it for really like the finer points and to really make it professional enough that an emergency physician that's been practicing for many years would get something out of it is tough. And that's the other thing that I'll mention too, is that like to write a case that a good case, it needs to be one that is going to also benefit people that are just starting practice, that not just like different career stages, like just starting practice, but are also 15, 20, 25 years into practice, but also different professions as well. And that's why I'm on a bit of a tangent here, but that's why bringing in other allied health like nursing and RT has been really helpful to develop the cases in a way that when we do these things interprofessionally, it's quite beneficial for everyone.
Yeah, that's a great point. We had not done that when we started. Again, we were just having our PAs, nurse practitioners, docs come and do these labs, and we started doing that team-based approach when we were going out to some of these sites, and it's a huge win, and actually kind of a team building experience when you get everybody together and run some of these cases. We've gotten lots of great feedback in making that transition. So sounds like you figured that step out ahead of us, but it's been a big plus on how we're doing this.
Yeah, it's tough. I was like, to be honest, like I was a bit resistant to it at first because I was a bit, not maybe resistance, not the right word, but apprehensive. Because I'd only done it for physicians, and when I was like, I don't know if you're going to get buy-in, and then you start to realize that the things that we want to know as physicians are the same things that nurses want to know, that RT want to know, and it really doesn't make a big difference in terms of what you're teaching. Like, yes, there are things that we just did a case in Chatham. It was a severe burn case with cyanide poisoning. And one of the main points, like everybody wants to know how the cyanide poisoning works. Why is it important? But, to have that extra piece that, when I brought in a nurse to also go through these cases, to bring in the piece of, okay, you need the cyanamide or the hydroxycobalamin. How are they going to mix that up? Because it's not easy. Like it actually takes a while to make it up. You need special tubing for it. And so when you do things like that, people get so much more out of it. But at the end of the day, everybody wants to be there for the same reason. They want to know how to take care of patients better and safer. And so that's, as long as you have that in mind, I think you're well on your way.
Well, that's music to my ears, because a big part of my shtick, if you will, is to break down silos. And so when I hear that we're having multidisciplinary or interdisciplinary simulation labs that are building bonds with nursing and RT and the clinicians, this is amazing. I mean, this is what healthcare delivery should be, right? I mean, I just love this. This is why I wanted to get the two of you together for this show. So it was everything I had hoped for. But we're hitting that magic 30-minute time window, and I'm always cognizant of that, as everyone's aware. We don't want to go on too long. I'd like to offer you both maybe one opportunity to impart a final thought, really anything you want. Hopefully something positive, full of hope, full of joy, or something about the work that you're doing. You can take it in any direction you want. And then if you'd like to put in one final plug at the end of that, please do that as well. Either of you want to go first? We could flip a coin.
I don't know that I have any inspirational moment. I think that we found a lot of benefit from doing these type of labs, and again, for all the reasons we've already discussed, better prepared. It definitely touches on provider wellness when you feel more confident in your job, and then again that social aspect of it, I think can't be emphasized enough. There's big wins in getting the team together outside of the stressful environment of the emergency department, and working on sharpening your skills. So we found tremendous benefit from this, and I love what Shawn's doing too. So
good stuff. And ECS's website, if I may, is ecs-wmi.com. Did I get that correct, Chris?
Yes.
Sweet. All right. I didn't, unlike screwing up Shawn's name at the beginning, I got the website correct. Shawn, if you'd like to impart one final thought or idea or what have you, please do so.
Yeah, no, I think what Chris said was wonderful. And I don't want to steal what you said, but I will just reiterate that one piece that I really liked what you said about, it's not just about the education, and it's also about socializing and being in a different environment with the people that you work with. I found so much benefit from that, and not just my own group, but again, we've been to about 20 plus hospitals, and it's so nice to see people interacting and laughing with each other and, just having a good time. But, the way that we do it is you can still do it in your environment. I'll say that much, because we try to do them in situ and in the emergency department. And I think that even sometimes brings more to the table. It stirs more conversation about how do we make this better? How do we move? Can we move the crash cart over here instead of over here? And can we, why is this not in the Pyxis or the Omnicell? And so, you kind of get those things going, and then people start talking, and then you hear about, I will often follow up with some hospitals after I've done the sim and say, what's changed for you? And it's so great to hear when I hear a whole pile of things have changed and it's made people's lives better. And so, yeah, I mean, it's such a wonderful thing. I really love doing it, and it's a great time to bring people together for the benefit of patient care.
Well, I love the positive ripples that you're both creating, to coin a phrase, so to speak. And then on that note, I got to impart a little bit of information regarding the book. Obviously, Ripple of Change, I co-authored with one of my former patients. We just updated the website. It's now rippleofchange.us, so a little bit easier to remember. And as always, what positive ripple of change will you create today?
Grab your copy today. Ripple of Change is available in hard, soft, and ebook formats. More information at www.ourquadrupleaim.com. Thanks for listening, and let's turn ripples into waves of lasting change. Stay tuned to this podcast as we search for examples of our quadruple aim.